but this is just a little bit about who I am first and foremost. I'm from a suburb of Chicago called Oak Park in Illinois. Um, as was just mentioned, I did medical school in Chicago at Rush. I trained primarily in psychiatry, so my residency was out there at the Medical University of South Carolina, MUSC. And now I'm currently at the University of Colorado. So I've been here in Denver for the last 10 months. And I trained primarily in neurology here and really, at this intersection between the brain, the physical brain, the neural networks, and the mind, and how that generates the things that we experience. And that's always been my interest and what drew me to medicine. And moreover, like any of us, I'm not, just my job. I have a background in a couple of other things. So after college, before pursuing medicine, I did this program in Japan called the JET program. It's a large international exchange program where they bring college graduates from America and other countries into Japan and employ them at and English curriculums in high school. So I spent a few years working with high school students in Japan. I have some pictures of my students here. I also really love the ocean. I scuba dive, and in college I had a pet octopus named Octopus Prime. In my hometown, Oak Park. I went to a high school that was also attended by some other famous people like Frank Lloyd Wright, Ernest Hemingway, and Dan Castellaneta, who is the voice of Homer Simpson. So that's just a little bit about who I am and where I'm coming from. But today, just to introduce the topic, we're here to talk about Parkinson's disease and mental health and how do those topics intersect. I understand that this particular seminar is for people that might have a new diagnosis and their loved ones, their caregivers.
Smoke detector? I don't know.
That's what we're going to be
I think
diving into.
change smoke detector things
And I
on
think
the
there's a
calendar.
little audio
We did.
coming from somewhere. If everyone could like mute maybe or double check that. Thank you very much. So, some background information first. Parkinson's disease is traditionally thought of as a movement disorder. Like probably everyone in this room has heard that. Parkinson's, a movement disorder, primarily involves the dopamine system in the brain. So, the dopamine system, dopamine is a neurotransmitter. It's one of many neurotransmitters that our brain uses to communicate. So, different parts of the brain send signals using these little molecules. One of them is dopamine. And dopamine, it turns out, is essential, especially in the networks that deal with movement. Dopamine's produced in these deep structures called the basal ganglia, and then long neurons project them out and spurt them out in areas where they're needed. So one of those areas is the motor cortex, where it helps initiate movements. Say you think to yourself, I want to move my arm. A little pump of dopamine goes from the basal ganglia to the motor cortex, and that helps you initiate the movement. But it turns out that dopamine is, like all neurotransmitters in our brain, it's used for a lot of different systems. And it's also really important in other networks that involve regulating our mood, regulating motivation, how we decide what's important to do, cognition, just thinking, processing information, perception, like interpreting visual information and data from our environment, and many, many other things. So this cartoon on the right is kind of like one of the traditional illustrations that's supposed to show all of the symptoms of Parkinson's disease. And our common, like the pop culture understanding is that it's all of these movement things like rigidity and a tremor and things like that. But there's all of these other these arrows on these brains show that it projects not only to the blue motor cortex, but all to these other regions like the frontal lobe, where we make decisions, our personality and our emotions are being regulated into these other areas. So people with Parkinson's disease, because there's an overall change in the regulation of this system, are affected out of proportion to the general population by mood symptoms and behavioral changes, which we usually don't talk about, but are super, super duper important. Um, and like any mental health symptom or condition or diagnosis, these things are really complex. They're usually influenced by many things, not only our neurobiology, but by any pre-existing mental health conditions you might have from earlier in life and what's going on in your life and the stresses and all kinds of things. So this is a complex constellation of things that manifests, but the regulation of the dopamine system and that getting out of whack makes people with Parkinson's disease at an extra state of vulnerability compared to the general population. So, I would add, if I could, to this diagram, some of these neuropsychiatric symptoms like depression, anxiety, perceptual changes, behavioral changes, all of which we'll talk about a little bit today. Um, so yeah, not a movement disorder, a neuropsychiatric disorder. This is a table that just summarizes some of those specific dopamine networks that involve and rely on dopamine. Not going to go into detail and put you through med school of every single one of these, but this just is to show you that. So yes, first and foremost, there's this motor system, and when that's dysregulated, we see tremor, stiffness, slowness, etc. There's a network called the medial orbitofrontal circuit that's involved in emotional regulation, integrates our senses with our emotions. So when that's out of whack, we can see dysregulated emotions, sensory abnormalities. There's a network that's involved in executive functions. Executive function means like planning things multiple steps ahead, multitasking, prioritizing things in sequence. And when that is out of regulation, those types of tasks can be more difficult. And then lastly, and very important for Parkinson's disease, there's a network called the anterior cingulate circuit. It's involved in motivational behaviors, deciding what is important in my environment, what motivates me, what's rewarding, what do I want to avoid. And when that system is out of regulation, we can see apathy or a change in motivation. And then the lateral orbitofrontal network is involved in kind of like social cognition, being aware of like other people's states of minds, what's appropriate to say, what's not appropriate to say in this specific situation. And when that gets dysregulated, sometimes there's problems with disinhibition, meaning a thought that you would normally think to yourself, but say, oh, I shouldn't say that here, or I shouldn't do that at this moment. It can just become something that's blurted out or more impulsive. This can also lead to compulsive like behaviors like gambling or other things that are intrinsically rewarding, but you just, can't seem to restrain yourself from doing. So we'll talk a little bit more about these, but I just again like want to underscore how important and an active area of research neuropsychiatric symptoms in Parkinson's disease really is. And I just before this talk did a quick search on clinicaltrials.gov, which is a national database that shows all the current research, all the active studies that are going on in the country right now, and just did a search simply for Parkinson's disease, depression, and there are 92 studies active and ongoing for that specific symptom even today. So it's not to be overlooked. And now from this point, I'm going to talk about some of these specific symptoms that are disproportionately, that can come up in Parkinson's disease, that we should be aware of so we can watch out for them. Depression is the first one. Depression occurs in up to 50% of people with Parkinson's disease at some point in their lives. And that's, greater than the general population, where it's maybe 10 to 20%. And it's also greater than people even with a general chronic medical condition. So it should really be something that's on our radar. And more severe depression, in most cases, it's like, mild and something that we can deal with and get through, but it can become more severe in 5 to 20% of people at some point with Parkinson's disease. So that translates to like 1 in 20 to 1 in 5 people. And so it's super common, very important, obviously, for our quality of life. And it's important for you all to know about because even though it's very highly prevalent, very common, it's under-recognized and not treated enough in clinical practice. And part of that is because not every neurologist has gone through mental health training or did a psychiatry residency like I did. And it may just not be on people's radar. It should be, but it's also up to us and our families to be aware that it's out there and to bring it up, talk about it early and often. So how do you recognize depression? Uh, most people would say the first thing that comes to mind is feeling depressed, right? Like I just feel sad, I feel down. And that is just one of the symptoms of depression and only one of the diagnostic criteria. So in addition to depressed mood or feeling down, these are some of the other symptoms and having, but going by the books, by the textbook, if you have at least 5 of these things plus a low mood, that qualifies for a diagnosis of major depression. So it's not hard to meet that criteria. Sleep disturbance is very common. So that can be either not sleeping enough, insomnia, or the opposite, like sleeping too much. A big one that a lot of people overlook, but like in hindsight, they're like, yeah, this was a big part of it, is a change in your like ability to enjoy things. So change in your interest or pleasure, and just not being able to get pleasure from things that you would normally enjoy. Other features can be just feeling guilt, feeling hopeless, worthless, or guilty, change in energy, where there's a fatigue, a loss of energy, not having enough oomph or energy to do the things that you want to do or are supposed to do day to day. Change in concentration, just like not being able to focus, say, like listening to a podcast, reading an article, watching a TV program, finding that you can't really maintain that focus to the end as much as you normally could. Changes in appetite, which can lead to changes in unintended changes in weight, like dropping your weight, gaining weight by accident. And this can be in either direction, just like sleep. It can be a change where your appetite is poor, which is a little more common, but it can also be having a much higher appetite than is typical. And then psychomotor agitation or psychomotor retardation. That's a little bit jargony, but it means a change in the way that you're physically moving, either moving more slowly and talking more slowly, or in a sped up way, like moving and talking more quickly in a way that you or other people notice. And you obviously, this and some of the other things might overlap with some of the other natural features of Parkinson's disease. And when we talk about these symptoms, we weigh that and we take it into account. And then the last feature of possible depression is suicidal thinking. And suicidal thoughts don't always occur in a form of like, I am gonna go get some supplies and actually kill myself. I'm, having a plan. There's actually a spectrum of suicidal thinking. And the most common way that it begins is actually just a passive thought like, my life's not worth living. I wouldn't mind if I didn't wake up tomorrow. It doesn't go beyond that most of the time. Probably 90% of the time never goes beyond that. But it's still a point along that spectrum that's important to pay attention to, because if we don't they take that into account and do something about it and try to make things feel better, it can progress and it can get worse. Um, so this, I circled this because just being able to get pleasure and enjoy things is so common and so often not considered. And when it's like, well, I don't feel depressed, but I just can't enjoy things the way I normally could. That's an important one to pay attention to. Before I go on to the next kind of bucket, I also wanted to say that the treatment for depression and for all of the things we're going to talk about is not dramatically different in Parkinson's disease as it would be in anywhere else in mental health care. So, just like you would treat general depression with anybody that's experiencing it or going through it. Some of the options are like psychotherapy, talking to someone, tapping more into your support system, and or medications. And the research shows that the best treatment in general is the one that the individual person wants. You're going to respond the best to the thing that you're motivated and you believe in. And when people do multiple things together, like medications and therapy, the outcomes are better than either one alone. The next kind of neuropsychiatric symptom that I'm going to talk about is apathy. Apathy is defined by having a loss or a decrease in someone's motivation to do goal-directed activities. Goal-directed activities means anything that has an endpoint, has an objective, something you're trying to accomplish. And that can be social, it can be monetary, it can be for fun. But people that are struggling with apathy have a drop off in that, where they are not necessarily depressed. Their mood is not necessarily bad. They might feel fine, but they just don't really have the motivation or the interest or the care, particularly in doing some of those things as much as they normally would. And a very important point with this and everything that we'll talk about, I'll say again and again that it's a change, or it's a different from what the person would normally do. A change from baseline. For some people, like if They don't do a lot of goal-directed activities, but they never have in their teens, 20s, 30s, and it never caused problems for them. And that's not what we're talking about, but we're talking about things that would be a change, something that's new, unusual, or atypical for this individual person, and or it's causing functional problems, getting in the way of living life in a new way. So apathy itself is also incredibly common in Parkinson's disease. And obviously, motivation can overlap with depression. When people are depressed, they often don't have motivation either. But it's important to know that this particular thing, apathy, can occur without depression, where the person's mood is fine, but their motivation is different. In that case, it's often the caregivers that are noticing or bringing this up. In my experience, there's saying like, I really need to tell my loved one what we're doing every day, or like really give them things to do because they're not doing things on their own. If left to their own devices, they are just sitting there. It doesn't bother them, but I need to get things done. So this is another slide from a paper, a graphic from a paper that just shows how apathy and depression can overlap, but they can also be different. So where they overlap is just like that loss of pleasure, maybe less energy, and mental and physical slowing. Obviously, that itself overlaps with non-psychiatric things in Parkinson's disease. But apathy without depression also has these features like just a reduced initiative, needing more prompting to start tasks, maybe not being as persistent in a task you started, but you're more quick to give up, being less interested in events around you, just blunted emotional responses, lack of concern. Whereas it can be with or without these other features of depression that we already talked through, like guilt, sadness, and those kinds of things. And the next feature I'm going to talk about is anxiety. Anxiety is also common, also in about 40% of people with Parkinson's disease at some point during their lives. Anxiety can take several different forms. These are some of the diagnoses, but it just shows that the anxiety could focus on different things. It could be generalized, where the person's worried and anxious about things overall or whatever's on their plate at the moment. It can also take the form of panic attacks. Panic attacks are a pretty unique phenomenon where it is short and intense anxiety that usually lasts for 15 or 20 minutes and can feel like a lot of physical symptoms like chest pain, breathing heavy, sweating, and a feeling like really something bad is going to happen, or I'm going to die, or I'm going to get hurt, even though there's no evidence of that. It just really feels strongly that way. And then 15 or 20 minutes, it usually goes away by itself. So very, very specific sort of appearance of panic attacks. And then social phobia. So in some people, anxiety is just really focused on specific situations, like being around other people, public speaking, things like of that nature. In some people, specifically with Parkinson's disease, anxiety and anxiety attacks can be associated with their symptoms, where at times where Parkinson's symptoms, motor symptoms are worse and it's harder to move your body, just like any of us, very naturally, if you can't move your body, that's a distressing experience. And that can be a trigger for anxiety quite commonly. And in some people, if they have effects from medications where the medication wears off and there's times of the day where it's really hard to move, those can be triggers as well. Anxiety and depression overlap very commonly, so it's not unusual to have both together, although they can occur by themselves too. Just like kind of I talked about some of the common features and symptoms of depression, how do you recognize anxiety? What are some of the specific features? So not being able to stop worrying or cut it off as you normally would be able to, feeling worried and anxious overall, feeling nervous. It can also, just like depression, manifest in physical symptoms. Very common is like muscle tension, feeling tense, achy, painful muscles. It's not on this slide, but also GI or stomach symptoms can be a manifestation of anxiety. Just like if I was in medical school and I had a big final exam, I might have a stomach ache. right, like 20 minutes before my test, or have to go to the bathroom suddenly in a way that's unusual. And then when the stress is gone, those symptoms go away. And that's just a product, that's a normal product of the way our brain and our bodies are wired together. Can also be just a feeling of restlessness or being unable to relax. It very commonly manifests in changes in sleep, just like depression can cause insomnia, anxiety. A very particular way it often comes up in anxiety is waking up too early, where, I set aside 8 or 9 hours to get really good sleep. I don't have to wake up. I set my alarm at 9 a.m., but for some reason, I'm waking up at 4 or 5 and I feel anxious, can't relax, can't fall back asleep. That's a really common experience for generalized anxiety. And then just like depression, it can have changes in concentration, distraction, and it can also kind of, usually not on people's radar, but it can come up as irritability, being more easily frustrated or snippy. That can be a manifestation of anxiety. And yeah, again, before I move on, just like depression, the treatments of anxiety are pretty much, we do the standard things. The important thing with all of these is to be able to recognize it, to be able to talk about it with your doctors, to get the resources that you need or want. So we've talked now about the most common three symptoms: depression, anxiety, and apathy. We're going to talk about some of the more uncommon and more specific to Parkinson's disease now, for the next few slides. So this one is about impulse control disorders. So impulse control, like I said earlier, is basically your ability to have a thought or have an impulse, but be able to stop it and compare it to the situation you're in and decide whether it's appropriate or not. Because of those frontal lobe networks that are important for executive function, when those change or they're not online in the way that they're supposed to be, this can lead to new behaviors, again, that are a change or something unusual for the person. But for some people, it comes up as like a new gambling habit or going on shopping sprees, compulsive eating, or sexual behaviors, even beyond, very importantly, beyond what would be normal for you, or in a way that gets in that interferes with your life, your relationships, your obligations. Um, these kinds of symptoms can be a part of just the natural process of Parkinson's disease, but they can also commonly be a side effect, sometimes from Parkinson's disease medications, especially medications that are delivering extra dopamine, because we know in PD, there's not enough dopamine in general. A lot of the medications and treatments, we're trying to replace or enhance the dopamine that is there. And when dopamine's overactive in those same circuits, it is really a risk for excessively doing some of those activities, because it's basically greasing the gears of all of the rewarding pathways, the things that are fun, exciting, and rewarding. So something to look out for, both as a general symptom and with any medication change. Um, Next, I'm going to talk about psychosis, hallucinations, and psychosis. So, because dopamine is regulating our visual systems and our sensory information, actually changes in perception and misperceiving or perceiving things differently is quite common. So, minor perceptual changes are the most common, about 40% of people with PD at some point, but those are usually pretty subtle. So these are experiences that all of us have probably had in life, especially if you're tired or haven't had a good night of sleep. You may think of times that you are at home in a dark room, say, and see like a little shadow or something seems to be in your peripheral vision. Or, I picked this image because it was posted online and someone like, it seems like I'm seeing someone in my doorway. And if you look closely, there's nothing there. There's like a little a vacuum or something in the doorway, but some of your brain's natural automatic data processing systems ramp up and they're like, oh, is that a person? Is that the outline of something? And you might temporarily misperceive it. And then we look closely at it and it's like, oh, there's nothing there. But that becomes a little more common or susceptible in Parkinson's disease. Now, frank psychosis, meaning seeing well-formed, like solid something there. It doesn't go away when I look at it, or I'm like strongly hearing something like a voice, Those are more common, more uncommon, and more rare. About 10% of people with PD will experience that at some point. Just like with the impulse control disorders, this can be a product of medications as well, where if there's too much dopamine in the system, that itself can be a cause of psychosis. And in fact, the balance of dopamine, not having too much, but not having too little, is key in finding the sweet spot where physical motor symptoms are controlled, but you're not having extra experiences that you don't want to have. And in fact, an interesting side point in people that have like a psychosis disorder, like schizophrenia, the main medications we use to treat those disorders are anti-dopamine medications. They're called antipsychotics, and they work literally by pushing dopamine back down. And so in Parkinson's disease, or the tricky thing for us to wrestle with is finding that balance and using some meds that push it up and some meds that push it down and not going too far in either direction. People with Parkinson's disease, if they have these experiences, most commonly they're visual symptoms. And that's very different from people with schizophrenia or people with primary psychotic disorders. They most commonly have like hearing voices or auditory. In Parkinson's, it's usually the visual system. For whatever reason, just biologically, that system's the most susceptible here. And so it's usually an experience of seeing something. That's by far the most common. Less commonly, maybe hearing things. And even less commonly than that, maybe feeling something tactile or smelling something, a smell sensation that's not there. And then when we talk about psychosis, it's not only directly seeing or hearing or feeling things with our senses, it's also touches on our beliefs. So a delusion means a false belief that is just fixed and it seems to get stuck. So these can be things like someone is out to get me, someone's following me, um, someone's listening to me, there's someone in the house. It might not be something you see or hear or directly experience, but it just is a sense, a feeling, or a belief that gets stuck, doesn't go away. That's called a delusion. This is less common than the visual changes, visual misperceptions. But I've seen the most common manifestation of that is paranoia, or a feeling like people are out to get me. People are doing something against my best interests. Um, the cognitive changes. So because the dopamine system is responsible for transmitting information from one part of the brain to another, comparing and contrasting, reaching a conclusion. Um, the most common manifestation cognitively in Parkinson's disease is a general slowing down of thinking. So generally, persons just as intelligent, knows and remembers everything just as well as they always have, but their processing speed is a little bit slowed down. Very similar to how our muscles and our movements might be a little bit slowed down. The best solution for that is just allowing extra time to collect one's thoughts, provide a response, because all the information, all the processing abilities are completely preserved. And that's very common. Doesn't usually need any intervention at all other than understanding people around you. Less commonly are objective impairments or changes in your actual cognitive faculties. These usually are very uncommon, like in earliest stages of diseases. If they're strongly present, it's a sign to talk to your doctor that maybe there is something else going on other than just Parkinson's disease that we should look for. But like with any progressive condition, later and later, as other areas of the brain are impacted, we can see changes in actual like memory or other cognitive domains, like being able to associate information, recall things, and use information. In the extreme form, we call this Parkinson's disease dementia, which is less common and treated in the same way as other memory conditions where we would give medications that try to help boost memory and cognitive performance. So just in summary, it's important when we're thinking about cognitive changes to know that cognition doesn't only mean memory. A lot of people, when they think about cognitive disorders, think, oh, it means my memory is bad. But it's important to recognize and realize that when we talk about cognition, we're also talking about processing information, the speed of processing. We're talking about attention, your ability to focus, your ability to plan, that executive function, like I talked about. organizing, problem solving. All of those are elements of thinking, not just memory. So what do we do? How do we manage these things? So first of all, it's important to be aware of the most common issues for yourself and to recognize and be able to bring up something when you need to. So I recommend that like everybody talk about these things early, talk about them even when they're not a problem. Ask your doctors, what kind of things do you look for psychiatric, neuropsychiatric symptoms? How would I manage it if this happened or that happened? And if you have a concern, bring it up, talk about it. When it's really important to seek help is if it's creating a situation that might be unsafe. So obviously, like with depression, if you're having thoughts that you don't want to be alive or want to take your life, that's an emergency. It's important to get emergency help, even by calling 911, going to an ER. Their doors are always open. And in less urgent cases, just talking to your doctor about it candidly. They're aware of it. Neurologists know about this, and they are going to be able to offer help. The other thing, second tier after safety and second most important thing is just your quality of life. So if these symptoms are something you're noticing, but it's not, but it is getting in the way, and it is getting in the way of like doing the things you want to do, being present in your life in the ways you want to. That's another sign that, hey, a treatment could help, whether that's therapy, a medication change, or anything. And then lastly, as I talked about, the dopamine system is really something that has to hang in the right balance. So anytime that there's a new symptom, something you haven't experienced before, especially after a medication is changed, like a new medication is added or a dose is increased, um, that's an important time to talk to your doctor. And they have to be aware of it so that they can help bring things back into balance. What kind of treatments are helpful? So when we think about changes in mood, depression, or anxiety, um, and if the symptoms are not urgent or mild and something that maybe we can talk through, therapy is a really great and helpful um, form of treatment and something that honestly, like almost everybody can benefit from, whether you're struggling or you're at a crisis point or not, and just dealing with the normal trials and tribulations of life. There are a few, just like medications, there are many different forms of therapy that work in different ways, have different mechanisms, and might be a good fit. So just some of the most common ones that you might hear about are cognitive behavioral therapy, CBT. This is a more structured type of therapy that's time limited. It's usually focused sessions. There's a goal for every hour, every meeting, and there's a set number of meetings where it's like 12 sessions. We're going to cover this. There will be homework and things to work through. And then we reach the end, we reassess, and hopefully we've met our goals. It's kind of like a, a prepackaged structured type of therapy. Supportive therapy is like kind of the opposite. It's more unstructured. It's about getting to know and working with a therapist and them just like listening to and supporting you through helping you problem solve. And it can be ongoing, less structured. And there are many, many other forms of therapy that I'm happy to talk to anyone about that's interested or thinking or working with someone specifically. Medications can be helpful, just like I mentioned earlier. The medications that treat these symptoms in Parkinson's disease are pretty much the same medications we'd use in any other situation. We have a lot of great options like for depression, for anxiety. It can be trickier to medically treat some of the other things like apathy. And usually it's a matter of adjusting some of the medications that the person's already on. Um, and like I alluded to earlier, the research shows that when people do medications and therapy together, at least for depression, the outcomes are far better than either one alone. So they kind of like work synergistically. And then lastly, the more you can prevent any of these things, strengthen your resilience and your ability to like take on challenges and take on changes. Um, the less severe and the more manageable those things will be. So strengthening your support system early, like before you need to, getting, strengthening those bonds with family, reconnecting with friends, joining the PD community, which, everyone here is taking part in right now, joining caregiver alliances, having support for caregivers themselves, and involving your healthcare team members, talking about your support system early goes a very, very long way towards preventing any problems before they ever occur. Um, the other thing, it's very important, I think, if you have a pre-existing mental health condition, which is very common in our communities, to just have, earlier in life, I already have depression, I have anxiety or bipolar disorder, schizophrenia. If you have something already that you're managing before before things are compromised or like influenced at all by Parkinson's disease, it's a really good time early on to make sure your care is optimized. You're on, treatment plans that work for you. You have a good care team that you trust and feel confident in. Optimizing those things early on is very important. And then, as I've said several times, talk with your doctors, talk about mental health, talk about any signs and symptoms that concern you. You're not going to catch them off guard. They may be the ones that are like, I should have asked you about this earlier, because it's something that everyone has heard about, but because we're often thinking about like the physical and focusing on that, sometimes it gets left behind, and it shouldn't. So bring it up, talk about it all the time, and then take medications exactly as prescribed. So this is mainly in reference to the dopamine medications, things like levodopa, things that increase or decrease dopamine in the brain. Some of those medications have very specific instructions. Some of them we have to take several times a day, or they're supposed to be at specific times with or without food. The more that you're able to be organized with that, take them as they're prescribed and be consistent, the more that we're going to help like keep that dopamine system in balance and consistent and not jumping around, which can cause issues. And then lastly is to know the common issues and symptoms that can manifest. And if you don't know what to look out for, it's more likely that we're not going to recognize it. So hopefully, all of the things that we talked through today help kind of put some of these things on your radar. And I hope and pray that like every single person in this room never experiences any of these things, but we have to know about them. We have to be vigilant, and if and when they come up, if we can recognize them, there's great options to help treat it and help make life back to normal again. And then most importantly, I think in uh, bolstering your support, increasing your resilience, is to remember who you are. Just like I talked about, like I'm not just a doctor, but I've had all of these experiences, weird hobbies, interests. These are the things that I value that are important to me. Just in the same way, like with any medical condition, any diagnosis, certainly with neurology or mental health diagnosis, I think there's a risk of people internalizing and adopting, like, okay, this is my identity now. And when that happens, I think it can be very tragic because if you adopt that as your main identity, your world can become small or things can become a self-fulfilling prophecy, things that may or may not happen. So the more that we can remember, hey, I'm this person, this is who I've been throughout my life. These are the people I love, and these are the things that I'm interested in, that I'm passionate about, and stay really connected to those things throughout your entire life, the more that we're going to be able to weather anything that comes up along the way with our support system. And with that, I have some time to answer any questions or just talk more about any topics that people are curious about. And otherwise, happy to talk in other streams as well.
Mhm. Hey, Kim has her hand raised. Kim, did you want to go?
Hi, yeah, hi, Dr. Seidman.
Hi,
Uh, so I was wondering, I'm the social worker here at PAR,
hi, Kim.
and I've been attending a bipolar all the month of April, put on by your psychiatry department.
Hmm.
Um, I'm wondering first what you think the numbers are of people with Parkinson's who also may have a bipolar diagnosis. They didn't have a good answer for me about that. And then what kind of medications are best to prescribe with their carbidopa levodopa medication?
That's a great question. Um, So, first question first. What is the rate of bipolar disorder and Parkinson's disease? As far as I know, the rate or the risk of bipolar disorder in people with Parkinson's disease is not higher, significantly higher than the general population. But of course, having bipolar disorder pre-existing does not protect you from Parkinson's disease. So like many people have bipolar and then get Parkinson's, and now you have both. There is a reverse correlation where, or at least in epidemiological studies, people with bipolar disorder themselves had a higher risk of later developing Parkinson's disease. So almost like the opposite correlation, which is interesting. And there's not a definitive reason for that. But we think, in general with mental health conditions, since just having, mental health symptoms, whether they're, when they're not controlled for long periods of time, that's a strain on the brain, right? And so any stress that we put our brain through makes the likelihood of developing other neurologic conditions a little bit higher. That's my own thought about why that might be. In terms of management of bipolar disorder, co-occurring with Parkinson's disease, the medications that we use for bipolar disorder in general are none of them are needing to be avoided. So common drugs like lithium or Lamictal, Depakote. Yeah, those are all, it's important, to consider the whole medical picture. But in terms of dopamine and Parkinson's meds, there's no interactions that would make one, inappropriate or off the table.
Okay, thanks.
You're very welcome.
Any more questions? I'm not seeing any more questions, so. Oh. Well, I'd like to thank everyone for coming, and I'd especially like to thank Dr. Seidman for being here. That was a very interesting presentation, and I think we all got a lot out of it. So thank you so much.
Happy to do it. Yeah, thanks again for including me, and great to meet everybody.
Thank you. Well, everybody have a good evening, and we'll hope to see you soon in some of our support groups or exercise classes. Make sure you take advantage of the things we have to offer. So, okay. Well, thanks, everybody.
Thank you so much. Appreciate it.
Good night.
Bye-bye.
Bye.